able to share my talk and follow the footsteps of so many luminaries in the field of prostate cancer and prostate health. Of course, today is Earth Day, so I hope everybody had a good Earth Day. I have no acknowledgements or disclosures. I borrowed some of these slides that I'm going to show you tonight from my good friend Peter Choyke, who is a mentor of mine at NIH, Mark Schultz, Jelle Behrens from Holland, who is also another mentor, Dr. Sadana and Dr. Poonen of University of Cincinnati and University of Miami provided some slides on focal, biomarkers as well as index lesions. So what we're going to cover tonight are the challenges with PSA screening, the growing role of prostate MR first prior to biopsy, the concept of the science of focal therapy with what constitutes an index lesion, and then to conclude with showcasing the TULSA-PRO MR guided focal therapy, which we're proud to showcase at our West Hills location. The state of prostate imaging is strong, and we know a thing or two because we've seen a thing or two. We started our program in 2009. We have over 12 years of experience with prostate imaging. RadNet has 21 Southern California locations capable of advanced multiparametric prostate MR. This is from Victorville to Temecula and inland to Palm Springs and now Phoenix, Arizona. We currently perform over 550 prostate MRs a month. We have a centralized core group of 4 people. We limit the readers to maintain our quality and outcomes. And our experience is critical to our success. Prostate cancer in 2018, as we know these statistics, 180,000 new cases, 9.5% of all new cancers, roughly 30,000 men unfortunately pass away, which is very similar to the same incidence and mortality of breast cancer. 1 in 8 men will be diagnosed, and many of these cases occur in men over 65. The nice thing or the good thing about prostate cancer, of course, is the 5-year survival is very high. So what's wrong with PSA? 85% of men with PSA don't have cancer. 15% of men with a low PSA do have cancer. It can fluctuate wildly in bike riders or men with prostatitis. And of course, the standard management, if the patient had an elevated PSA, he would go to the urologist and they would stick 12 needles into the prostate gland under ultrasound, which lacks sensitivity and can cause harms of bleeding and infection. So PSA is a compound expressed by the prostate. It goes in the bloodstream and can be measured. We don't want to admit the physical exam. Some men with a low PSA have a nodule, and the only way to pick it up is with the physical exam. And here you can see that the needle misses the tumor, and there are over 1 million prostate biopsies performed each year, and I think we can do better than the standard. So the problem with the trust biopsy is that you can see that here the needle goes in to the prostate gland and a big cancer was missed. In this case, they found a insignificant low-grade cancer while they missed the index lesion or the more aggressive larger lesion. Or in this bottom case, they got a Gleason score 6, but they didn't sample the higher grade tumor that was more central in the lesion. So with standard trust, there's roughly 1/3 of the men are undergraded when they compare the histology to the final pathology at prostatectomy. So Gleason score is a predictor of aggressiveness. We know it goes from 6 to 10. However, random trust doesn't have accuracy for providing the true Gleason score. Most urologists use a modified 10 or 12 core sextant grid to sample the gland. So therefore, if you just base your data on a trust biopsy alone, it can result in inappropriate therapy. So many times the urologist would say, well, we know prostate cancer is multifocal. We found a small volume Gleason 6. We don't know what we didn't hit. So we want to recommend prostatectomy, put the prostate in a jar, and you don't have to worry about it. And that was part of the problems with PSA screening. Our buddies in Washington, the United States Preventative Task Force, concluded in 2008 that PSA screening did not work. And they focused on the harms of finding low-grade tumors. Urologists were performing too many biopsies and not finding enough cancers. What we do is we feel that the PSA density can be a more useful biomarker in men with a negative prior biopsy. And there were too many false positive biopsies simply based on an elevated PSA. And men heard that the biopsies were uncomfortable, and then they didn't want to get screened. So here's some interesting data. When the government stopped the recommendations of PSA screening, not surprisingly, we found an increased number of metastatic prostate cancers. So from 2008 to 2016, the percentage of men presenting with metastatic prostate cancer rose from 6.4 to 9.0. During that same time, the percentage of men getting PSA screening dropped from 62% to 50%. So this was statistically significant data that the lack of PSA screening led more men to present with advanced stage disease. The task force modified their guidelines in 2017, but they still gave it a C rating. The updated statement continues to stress the risks of overtreatment. They wanted to have individualized approach and discussions with the physician and patient before they got a PSA. The recommendations are to only screen men between 55 and 69. And unfortunately for men over 75, they still gave it a D. But as we know, many men are living much longer lives until their 90s. So we feel it should be based on their relative health. And if the doctor feels that their health is such that they'll survive at least 5 or more years, they'll have a benefit from prostate cancer screening. So with screening, the Europeans have done a better job than us in the States. The Europeans showed mortality reduction of 31%. The Swedish trial showed a mortality reduction of 44%, but it came at a cost. They shouldn't use PSA alone. We want to add MR. Apply risk modifiers, which is multiparametric prostate MR. We want to identify indolent disease. Well, MR doesn't see or pick up these small baby Gleason score 6s, so we don't care if we miss those, but we want to develop better biomarkers. This slide I borrowed from Mark Schultz, and the life expectancy after relapse with prostate cancer is around 14 years. And this is important because it is challenging to prove benefit of screening when it takes 14 years of outcomes to be able to demonstrate mortality reduction. So why diagnostic prostate MR? You can't solve a problem if you can't see it. The prostate was the only organ in the body that was being biopsied blindly or under rectal ultrasound guidance, which was very insensitive. So here with MR, you can see a large area of decreased signal, which is a tumor. We can look at it in a coronal orientation. We can see here that it's invading the seminal vesicle, and diffusion imaging is really one of the most useful, powerful tools to allow us to identify and detect cancer. So quick review of the anatomy of the prostate gland. There are 4 distinct histologic zones. The anterior fibromuscular stroma has very scant prostate tissue. The transition zone is in the center portion of the gland and increases in volume with men who have prostatic hypertrophy or BPH. The central zone is up here near the base, and these are the ejaculatory ducts. And the peripheral zone is this high signal that we see in the periphery of the gland closest to the rectum. So most of the prostate cancers occur in the peripheral zone, and roughly 1/3 of them occur in the transition zone. Everybody, I think, is familiar with Pi-rads, and Dr. Cohen in our group was one of the initial Pi-rads committee members as part of the ACR and the international working groups. We've now modified that to Pi-rads version 2, and we've recently changed it last year to version 2.1. So just to quickly summarize the importance of Pi-rads, we break it down into the peripheral zone and the transition zone. So the key factor in the peripheral zone is diffusion weighted images. And in the peripheral zone, the key shot or the key sequence is T2 weighted images. So Pi-rads 1 and 2 are very low risk for tumor. Pi-rads 4 and 5 has a higher risk of tumor. So in the peripheral zone, we want to see significant restrictions of diffusion. And the only difference between a Pi-rads 4 and a Pi-rads 5 lesion is size. So if it's 15 millimeters or bigger, it's upscored to a Pi-rads 5. Or if we see aggressive features such as extraprostatic extension or seminal vesicle invasion, it gets upgraded to a 5. And in the transition zone, we're looking for lenticular or non-circumscribed smudged charcoal or decreased T2 signal. Again, a 4 is less than 15 millimeters and a 5 is 15 millimeters or greater. So here we have an example of a normal prostate on the right side of the screen. And here on the left side of the screen, there's an abnormality. And I'd like you to figure out if you can identify what's abnormal. So when the urologists typically do their biopsy, they place the biopsy gun on the rectal wall and the needle shoots in 2 centimeters, but there's 3 millimeters of dead zone. So they tend to be very good at finding cancers here in the peripheral zone, within 2 centimeters from the rectum. The area that they have a challenge with hitting accurately is the area in the transition zone furthest away from the rectum. So in this patient, there's a fairly large transition zone tumor that we can easily see with MR that would be in the past more challenging to detect. So why prostate MR? We now have level 1 randomized clinical control evidence from both the PROMISE and PRECISION trials. In summary, the PRECISION trial was an international trial which asked the question, how would MR prior to the first biopsy prevent overtreatment by finding clinically significant cancer? The enrollment was biopsy-naive men randomized into either a systemic arm with the standard ultrasound guide biopsy or MR prior to biopsy. And the limitation of this study was that they only had a biopsy if the MR was positive. So if the MR was negative, they did not do a biopsy. So there was poor control for what MR might have missed. But with this strategy, there was a 12% increase in clinically significant cancer identified with MR, and they decreased by 13% the number of men with insignificant cancers found by chance by standard truss. The standard truss arm had 3 times more needles, leading to more harms. So the weakness of this trial was, what was missed, but clearly the evidence was very clear. The PROMISE trial, I think, was a better trial. It had 576 men with a PSA of less than 15, all of whom were biopsy naive. They did a transperitoneal mapping biopsy first, then they did a 12-core truss biopsy. Their definition of clinically significant cancer was more restrictive than most of the other trials in the literature. They used the definition of Gleason score 4+3, or a core length greater than 6 millimeters. The standard definition of clinically significant cancer is Gleason score 3+4, that is 0.5 cc's in volume or greater. That would be 10 by 10 by 8 millimeters. So when they saturated the prostate with all these needles, they found 71% cancer detection rate, of which 40% met their definition of being clinically significant. The MR arm had a sensitivity of finding clinically significant cancer in 93% of men. The negative predictive value of MR was higher than the ultrasound guided mapping, 89% versus 74%. So in the 27% of men that had a negative MR, 17 out of those men did find prostate cancer. So there was an 11% false negative rate, but yet these men still had high-grade cancer. So standard PRUS missed 119 cancers, MR missed 17. So again, with MR, even though it's not perfect, it's still a much better strategy. And with the men who had the transperitoneal mapping, 44 of these had serious adverse biopsy complications, including sepsis and bleeding. So if we use MR to triage, we would reduce by 27% the number of men not needing a biopsy. And you would miss 5% of clinically insignificant prostate cancers. If PRUS was directed by MR, we would find more clinically significant cancer. And now London requires all men to get a MR first prior to their biopsy. They have to get it done within 30 days of the biopsy. We feel that by adding the PSA density of greater than 0.15 reduces the false negative rate further to 5%. Steve Raymond and his group at UCLA really popularized the concept with prostate MR by including the PSA density. That's simply taking the PSA level and dividing it by the gland volume. So if you have a PSA of 10 and a gland volume of 100 cc's, your PSA density would be 0.1, which is normal. And in the European Association of Urology in 2019, a Dutch paper looked at biopsy-naive men with the MR pathway versus PRUS-guided biopsy, and they only missed 4% of clinically significant cancers by doing the MR, but they reduced significantly by 50% the number of men needing biopsies, and they reduced the detection of baby insignificant tumors. So again, the urologists sometimes have been reluctant to embrace the concept of MR first, talking about what we miss, but don't let the perfect be the enemy of the good. It's time to embrace magnetic resonance imaging before the first biopsy because it's still the most effective strategy. And Faith Stern, who's the director of the ADMETEC Society, many of whom you know of her work and their great organization, this is where I think we're all trying to get to. The bottom line is radiogenomics, integrating liquid biomarkers, imaging tools, and cancer genetic profiling is going to be the future of precision care for prostate cancer. This was from the consensus statement from their meeting in 2018 that I attended. So the question is, should we omit standard 12-core PRUS biopsy? If you omit the standard, you will miss a few significant tumors, but you will reduce overdiagnosis of indolent tumors. So we want to counsel men that if the MR unfortunately is a false negative and you still monitor them closely with PSA and it's detected the following year, usually there's no change in treatment or outcome. But we need more data before we can recommend a targeted biopsy under MR instead of the 12-core biopsy first. And yet again, there was another study by my good friend Peter Choyke and Baris Turkby, published in the New England Journal of Medicine. So they talked about what does MR-guided biopsy miss? So the positive predictive value of detecting clinically significant cancer is over 85%. The negative predictive value of a Pi-rads 1 or 2 and excluding significant cancer is around 88%. To put that into context, when we do mammography for women in breast cancer, when we send a woman for a breast biopsy, we only find cancer 25 to 30% of the time. In other words, 3 out of 4 women who go to a breast biopsy find benign findings. Yet when we send men to a prostate biopsy, we find cancer in a significantly higher percentage, which I think is very important. In the NIH trial, they had 59 patients. A quarter of them were biopsy naive. 72% of the biopsies revealed cancer. So what they did is they biopsied areas that looked normal under prostate MR. And they found 10% additional clinically significant cancers that were silent or not appreciated on the initial MR. Why does targeted MR fail to diagnose all significant cancers? So there are a couple reasons. Equipment and protocol related. 1.5T versus 3T. We're much better if we're using a 3T or a high field magnet. Endorectal coil, biparametric, in other words, not using IV contrast, and having a study with significant artifacts from increased gas in the rectum limits our accuracy on diffusion. Reader variability. Not all prostate radiologists have the same experience or accuracy. You want to make sure that whoever is reading your exam has experience and does a practice audit so they can tell you how good they are. And even with the best of times, some tumors are just silent on MR, just the way they are in breast cancer, like a lobular cancer. And then there's interlesion Gleason score heterogeneity. Even though we may find something suspicious, the pathology may be wrong. And then with biopsy failure, with ultrasound MR fusion, it may not register correctly. We may not have enough needles going into the sample lesion. The more needles, if you increase it from 2 to 3 or 3 to 4, you increase the yield of trying to hit a targeted lesion. There is inconsistent training and certification of urologists using fusion software, and a lot of it depends on the gland volume and the size of the lesion that you're trying to hit. We sometimes find 4mm lesions, and they can be very challenging to hit. So if we triage men who would benefit from biopsy, we can reduce the number of benign biopsies. We can find more clinically significant tumors. And of course, the important thing with this is we can assign men to active surveillance with higher confidence. Instead of being told that you have a small volume Gleason 6 and we might miss something, let's take your prostate out. If you've had an MR first and a 12-core biopsy under guidance, we can keep you in active surveillance with confidence. And then of course, this is a very cost-effective strategy. So now moving on to biomarkers. Biomarkers is a whole panoplia of different options. Some urologists like the 4K score, some like the Phi test, select MDX, PCA3, or the exosome DX. How do these work and how do they increase our accuracy? So here's a slide talking about an increasing 4K score percent and what happens when graphed against Pi-rads 4s and 5s. So when you have Pi-rads only, they found 78% cancer detection. The 4K score was very comparable to that. The problem with a biomarker is it doesn't tell you if the patient has prostate cancer at the time the study was done, and it doesn't tell you where to biopsy. But when you combine prostate Pi-rads with 4K, you increase the accuracy. So I think it's a useful tool. And similar concordance with PCA3, when you compare the PCA3 with MR, with each step, we increase our accuracy. So to avoid unnecessary biopsies, negative and positive predictive value, this is with the 4K risk calculator. So just to summarize this, they used a PSA level of 3 or an abnormal physical exam. So this was the 4K first, and then they only got an MR if the 4K was elevated. So the clinically significant cancers were 97%. In this case, they did an MR first and a 4K only if the MR was negative, and they found 97.3%, so same. And strategy 3 was MRI and PSA density if MR was negative. And with the PSA density, the cancer detection rate of clinically significant cancer was 98%, with a better false negative rate of 85%. So the 4K score added information, the MDX and the exosome DX. The exosome DX is a urine test, and the MD Select is a blood test. And again, they're all useful to figure out who to biopsy and what to do with the information. but these studies have costs. The 4K cost roughly, the last I checked, roughly $400. The exosome urine test was around $800. At a RadNet facility, a prostate MR with contrast is between $500 and $800. So in my feeling, the strategy is to screen with PSA and MR and use the PSA density, which we provide as free as part of our MR reports. So if a patient has a Pi-rads 4 or 5, they're going to get a biopsy. I don't think adding a biomarker is going to help. If the patient has a Pi-rads 1 or 2 and a normal PSA density, I think they're going to not have a biopsy recommended. So I think the role of biomarkers are for the Pi-rads 3 to tip you one way or the other, or if the patient has a PSA density of greater than 0.15 and a negative MR. Then I think the role of biomarkers can clearly be useful to help guide patients who should have a biopsy or not. So we don't have the right sequence. We're trying to do trials to compare the different markers head to head and to figure out how to use these appropriately. Future directions with imaging is we're trying to use very fast MR techniques without IV contrast or biparametric MR. The work with Dr. Otto in Chicago is using spatial texture diffusion. By doing this without contrast, we can lower the cost and increase access, and we can establish a mammogram similar to men or what women get with a mammogram. RadNet is also working with people in Boston for artificial intelligence to improve our accuracy. And we also feel, we'll talk about this at the end of the talk, with focal therapy and genomics to tailor therapy to figure out which men may have a genetic predisposition for more advanced disease. So in a recent study that came out in JAMA in March last month, MR first screening would reduce the death rate by 18% versus no screening. It has the benefit of fewer harms, but we need to use genetic risk factors. The best case, if we screen men with a 3.5% risk of prostate cancer of a 10-year timeline, half the men could have an improvement in who would need a biopsy. And it reduces overdiagnosis, in other words, false negative diagnosis by biopsy by 27%. I'd like to show you two cases of what prostate MR looks like and how it can find cancer. And our first patient was a 78-year-old man presenting with a PSA of 7.9. The MR was done just 3 weeks before the biopsy. He had a prior surgical TURP, which was benign, and he had 2 rounds of benign standard ultrasound biopsies. So here's an axial image, and there's an area of decreased T2 signal in the peripheral zone that we can measure. And then this is the diffusion weighted image. So ADC, the applied diffusion coefficient, has decreased signal, and we can measure that and get a value. And there is an inverse relationship of aggressiveness. The lower the ADC value, the more aggressive the tumor. And with Pi-rads, we need to see it correspond to an area of increased signal on the high B value diffusion. We use a B value of 1400. So this would be a concordant decreased T2 signal in the peripheral zone with significant restricted diffusion. We can see that it enhances markedly with a nice washout curve. And we can measure the volume and calculate that this should be a relatively high-grade tumor. We can then identify where the worst kinetics are to help guide the biopsy to get the more aggressive Gleason score. And then this is what the gland looks like when we perform fusion for UroNav for an ultrasound MR fusion biopsy. What we've identified is the little golden BB here, and this is what the urologist is aiming for, and this is embedded on a 3D rendering that is fused with their ultrasound. So this allows the urologist to be very accurate to try to hit the most suspicious area in the gland. So when this was targeted, it showed a Gleason score 4+3 with extracapsular extension. and seminal vesicle invasion, and the rest of the cores that the urologist did, the other 10 cores were negative. In case 2, this was a patient, 85 years old, presenting with a PSA of 35. His PSA was roughly half of that 3 years earlier. He had a big gland with a PSA density of 0.35. He was on Flomax for BPH. He had 4 rounds of benign ultrasound-guided biopsies, including one 3 weeks before the MR. No family risk factors, so he's had at least 48 needles in his gland, and they didn't find anything. So in the MR, here in the ventral transition zone is an area that we call smudged charcoal. This is what happens in the TZ, where the significant imaging sequence is T2 weighted imaging. This also shows significant restrictions of diffusion. The black and white sign and significant restricted diffusion. And it also showed asymmetric early enhancement in the gland. So here we can measure the volume, so we know it's clinically significant. It's greater than 0.5 cc's. It's probably further away than 2 centimeters from the rectum, which is likely why it was not sampled on the prior biopsies. And here you can see we did a fusion on it. And when the patient went to fusion biopsy, they found grade group 3 disease. And these are the areas typically missed by TRES ultrasound. So the moral of the story is don't keep doing the same technique when the first biopsy is benign. Get an MR, and if we see an index lesion, do a targeted biopsy. Let's talk a little bit now about focal therapy and what are some of the options. I know Dr. Pugach gave a talk a few months ago on HIFU. So one of the forms of focal therapy is laser ablation. It's often done under MR guidance, but the limitation of laser is it has a limited treatment field. It's very good at hitting one index lesion, but you cannot do total gland ablation with laser. Cryotherapy is a outpatient in-office procedure where urologists would stick a cryotherapy probe into the prostate and generate an ice ball under ultrasound guidance, but it's very hard to obtain precision and to maintain cell death with accuracy from the freezing. Guided IMRT radiation therapy can be very effective. And HIFU, the standard HIFU from Sonoblade or Ablatherm is given transrectal, and it has challenges in that it can't treat a very large gland. So a lot of these men are encouraged to have a simple prostatectomy to reduce the gland volume prior to the procedure, and there could be inadvertent rectal wall and neurovascular bundle damage. And again, there's no direct thermal mapping.
Let me help you take it out.
So some of the complications of Sonoblade HIFU is that you can get inadvertent heating, and you can see the edema here of the anterior rectal wall. You can also see that the pelvic sidewall muscle is showing evidence of heat injury as well. And of course, the neurovascular bundles live back here as well. But this is what the donut sign looks like when you have successful coagulation of the tumor. You decrease the blood supply, and on post-contrast imaging, we see this donut sign. So your life shouldn't have to change if you're diagnosed with prostate cancer. And let's talk about why focal therapy works. Focal therapy, the treatment that aims to eradicate significant cancer within the prostate and at the same time preserve uninvolved prostate tissue with the aim of preserving genitourinary function. If we can preserve tissue, we'll have improved functional outcomes for men. So the shortcomings with treatment strategy was we only had radical prostatectomy or active surveillance. Those were your only 2 options before we had focal therapy. But we need to tailor the treatment to the biology of prostate cancer. And now that we have MR, we can see the tumor where before we never could. So we know that there are 190,000 new cases of prostate cancer. Many of the men are low risk and assigned to active surveillance and don't really need focal therapy. The majority of men receive definitive therapy, and unfortunately, there are side effects with that regarding bladder and sexual function. And when you look at outcome trials looking at radical treatments published in the New England Journal of Medicine, radical prostatectomy reduced disease-specific mortality, but there was no difference in overall survival. The PIVOT trial, radical surgery did not reduce all-cause or prostate cancer mortality. And the mortality from prostate cancer was low and not different, irrespective of the different treatment arms. So this is one of the challenges, that even with surgery, there is frequently positive margins or spread of disease. And when you look at all these trials, it hasn't really impacted overall survival. But it does show a significant decrease of urinary and sexual function. So we'd like to think that men should be able to evolve like women. When a woman in the 60s was diagnosed with breast cancer, the treatment was a radical mastectomy, taking down the muscle to the chest wall. And then they got lymphedema and all these complications. And finally, women evolved, and we had mammography, we had image-guided needle biopsies, we had breast conservation. So we've gone from the ape and we've evolved to the upright man, where we're curing the cancer and reducing the harms. So with focal therapy, we want to be able to provide the same benefit to men by identifying the index lesion. John Feller in some early talks talked about the index lesion when he was doing his laser ablations. We know that prostate cancer is multifocal, but it's the index lesion that drives biology. The largest lesion in the prostate contains the highest stage and grade of tumor, and this has a potential then for being targeted. And when you look at some studies on cell lines from high-grade and metastatic prostate cancer, you have a heterogeneity of biology within the prostate cancer. But if you look at which cells created metastatic disease, it's the purple cells here which led to the metastatic disease, which was the index lesion. So if we can see the index lesion and we can ablate it, even though we may not treat all the small lower grade tumors, we're going to have similar control as men who've had robotic prostatectomy regarding outcome. So with MR, we can see the index lesion in over 92%. We can increase that with biomarkers and more biopsy needles. And since we can identify the index lesion, then we can treat it with focal therapy. So the paradigm with prostate cancer is, do your MR. If you find cancer, you can consider whole gland treatment, focal therapy, or active surveillance. And that's what we want to provide men some choices. So the cancer diagnostic pathway is changing. We want to stop from either active surveillance or surgery and give men a intermediate treatment pathway for men who meet inclusion criteria. And prostate cancer treatment should be complementary and not exclusive. So we think this is very revolutionary. The TULSA device is different than the other forms of focal therapy, and we're going to get into that now. This is the March issue of the Journal of Urology, focusing on the TULSA method of focal therapy. So what makes TULSA-PRO different than the other forms of focal therapy? The heat source is inserted through a urethral applicator. There are 10 5mm ultrasound crystals that can be individually controlled by the treating computer. So we're heating the gland from the inside out. By using the transurethral direction, there's water cooling in the urethral applicator, so that reduces the risk of injury to the urethra regarding stricture. There is a rectal probe that's put in that cools the rectum to reduce the incidence of a rectal heat damage. and it's capable of treating both large and small prostate tissue, and it's a closed loop feedback system where we get real-time thermometry under MR, which provides gentle and precise ablation. So if you look at the video, the urologist places the urethral applicator into the prostate, we contour the gland, we figure out which elements need to be heated, and the heat goes in a radial fashion from the inside out. The yellow color signifies heating the tissue to between 50 and 52 degrees centigrade, which is a reasonable temperature for cell death and coagulation. And you can see the precision where we have within 1 to 2 millimeters of stopping the heat at the contour of the gland. So we spare the pelvic sidewall muscles, we spare the rectum, and we can spare the neurovascular bundles. So this video is sped up for this presentation, but the total real time for treating and ablating the entire gland was roughly 30 minutes. So we feel that this is an outstanding option. And here's what the TULSA system looks like. The urethral applicator is positioned in a robotic arm that's controlled in the workstation. We have a heat energy system to deliver the high intensity focused ultrasound, and the radiologist and the urologist work together in the control room to, under real-time monitoring, safely perform total gland ablation. And these are the disposable applicators for safety. So we can either treat the whole gland, we can do a targeted hemigland, we can treat men who have a recurrence following radiation therapy. Before, if a man had radio-recurrent disease, most of the time they weren't a candidate for surgery because of the scarring associated with the radiation around the prostatic tissues. And they were limited, they couldn't get additional radiation, so they could only go on ADT or hormone manipulation. But now, if the failure is contained to the gland itself, which it frequently is, we can treat those men with TULSA. We can also use it for treating BPH, which they use in Europe, but I'm not convinced it makes a lot of sense to do here in the States. But we can also, if we have a tumor, we can treat the BPH and the tumor at the same time. So again, we can spare the neurovascular bundles. We can do hemigland. We can treat BPH, and we can work with the patient and the urologist to create an appropriate treatment pathway. So the evidence of how TULSA came into being with the FDA is they started this work in 2000 to 2012. They had a clinical feasibility study. They did a treat and resect where they treated the tissue, and then these men underwent prostatectomy. And then they had phase 1, and they completed their TAC trial, which was approved by the FDA in 2018. And then we got our device last year in 2020. So if you look at the long-term outcomes, we can see that we can reduce the prostate gland volume by over 90%. So there were 13 institutions between US, Canada, and Europe, and it was demonstrated to be safe and efficacious. So there were 115 men enrolled in the FDA trial, all of whom had low or intermediate risk prostate cancer. The whole gland was treated, sparing the urethra and the sphincter. And the endpoints were to see a PSA reduction of over 75%, and then to look at gland volume reduction. So at 12 months and PSA nadir, you can see that the pre-treatment PSA was 6.26. At 12 months, it was 0.5. You can see that their IQR and other scores were excellent, and these were both statistically significant. When we look at the histology, you can see grade group 2+ disease, high volume grade group 1, low volume disease, or people who are missing biopsy. So on baseline, most of the men had grade group 2 disease, and at 12 years on follow-up biopsy, most of the men, 80% of the men roughly, were cured of their cancer. 20% of men had residual disease, but only 15% of them were significant. And when we look at radiation therapy for outcomes, only 55% of the men were cured without evidence of disease on follow-up biopsy. So TULSA is better and safer for appropriate patients. So the ablation efficacy was 80% disease control at the 2-year timeline. So 23% of men had high volume grade group 1 disease, and 23% of men had any disease. And when we look at volume reduction, here's the initial MR. This is what it looks like when we've completed the treatment. We give contrast and we show that there is no blood flow or perfusion within the gland. And then over time, the gland scars and shrinks. So the gland volume and PSA go down appropriately, and we can monitor that. So for men in this trial, the men who were potent at baseline, most of the men returned to their baseline function. There was a recent study that men who had a prostate biopsy had a drop of erectile function just having a biopsy. So any intervention at all causes a small drop, but this is much better than compared to other forms of treatment. And of course, urinary continence is exceedingly high, where over 98% of men have no problems with bladder control. So when we look at the functional outcomes at 2 years, only 2.6% of men had incontinence, 1% of patients had daily leakage, erectile dysfunction was very well preserved. So we can see that the prostate volume decreased 92%, and by 2 years, 7% of men underwent additional intervention for their prostate cancer. But let's compare that to other forms of treatment to put that into context. When we look at the quality of life at 12 months and 2 years was excellent for the men in this trial with TULSA. And here, if you look at the ablatherm and profound, with the transrectal form of HIFU, there was a 60% gland volume reduction compared to the profound of 90%. The PSA reduction of PSA was greater with profound rather than with ablatherm. And when we look at adverse occurrences, 34% and 12% at 2 years. With the TULSA form, only 7.8% had an adverse effect, and none of men had recurring complications at 12 months. So erectile dysfunction was much better with profound. Urinary continence and urethral strictures were all much better with profound than with the other form of HIFU. So when we look at TULSA with the biopsies, erectile dysfunction, urinary continence, urethral stricture, and GI toxicity compared to prostatectomy, many of the urologists I know report erectile dysfunction of around 10% in surgery. This may be a little high. Urinary continence is a little worse with surgery than with TULSA. Urethral stricture, when they anastomose it, is a little bit higher. With radiation, there is moderate erectile dysfunction. There's lower than surgery urinary incontinence, but they have more significant rectal or GI toxicity. That's being now mitigated with the hydrogel placement. But again, with the other types of HIFU, the complications and control is worse than with TULSA. So when we look at what a urologist says, for every 100 patients who he performs a prostatectomy, 20 will recur, 60 didn't need it, and 20 will benefit. So active surveillance accepts 20% of progression to radical therapy at 2 years and 50% men needing a definitive therapy within 10 years. Radiation therapy has around a 30% recurrent rate, and prostatectomy also has men needing additional treatment. So the initial trial of 20% retreatment rate is comparable, if not better, than the other forms of treatment. Since this trial was done, there's been an improved learning curve and improvements in the technique, and I'm confident we'll have this number down to around 10% in the near term. So we're providing this at a clinical site at our West Hills facility. We do this as a team with urology and anesthesia and nursing. So there's a whole team of people. The challenge with TULSA is that it's not covered by insurance. So patients can access an HSA account if they have it. They can pay cash, or we have financing available. We need and include a follow-up MR. So this treatment is faster than sonoblate. We can perform total gland ablation rather than partial, which is a benefit against laser and cryotherapy. And the key thing is the local urologist maintains direct patient involvement. We want the patients to maintain the relationship with their local urologist. They can maintain the pre and post care, and they can be treated at our center, or if the urologist wishes to learn this technique, we'll welcome them to treat their patients at our site. So inclusion and exclusion criteria. All men need to have a prostate MR and have a visible index lesion. They have to have a targeted biopsy plus the standard 12-core biopsy. We want to make sure to know if there's additional disease that we don't see, so we can include that in the treatment field. Men who are progressing on active surveillance who don't want surgery. We can treat men with large volume grade group 1, grade group 2, or small volume grade group 3 disease. We cannot treat men who've had hip replacements. We don't get an accurate heat map with the artifact from the hip prosthesis. We obviously can't do patients who've had a pacemaker, and the UroLift staple device for BPH creates too much artifact. So at this time, men who've had a UroLift are excluded. Regarding gland size, the lesion can't be more than 3 centimeters from the urethra. That's the length of tissue that can be heated with the TULSA device. If the patient has large calcifications between the heat source and the index lesion, the calcifications will absorb the heat source, and we may not get effective control. We can do salvage from radiation therapy failure. So we want to have discussions with the urologist and the patients as we evolve and get more experience with focal therapy. So just in summary, we started with what was wrong with PSA, how we can improve cancer detection by adding MRI and biomarkers, and changing the paradigm and providing men the same benefit that women get with breast conservation by doing focal therapy and by doing it effectively with the TULSA-PRO device as compared to other forms of focal therapy being performed in the marketplace. Thank you for your time and attention.
Okay, I think we're going to open this up for question and answer. Thank you very much, Doctor. That was fascinating. Certainly, I find it very hopeful. We have a question from Maury Hartman. Dr. Princenthal, have you seen any data, including the gallium-68 PSMA 11 nuclear medicine scan? Maury, I'm going to put you in here to, is that clear enough, doctor, or do you need a little more?
Sure.
All right.
Doctor, could you, Doctor, this is Dave, could you end your sharing and we'll look at all the participants? Oh,
How's that?
yeah, thank you.
So the question is, what is the role of PSMA imaging with prostate cancer? Right now, PSMA and Aximen are only approved for men with biochemical recurrence. There were trials that RadNet was part of looking at PSMA for pre-treatment pathways for a high-grade disease to see if they had metastatic disease, which might preclude them from being a candidate for surgery. That trial's been closed. So right now, most of the F18 PSMA analogs are for research, and at RadNet, we don't have access to the gallium PSMA. They do at UCLA. So PSMA can be very useful for cancer detection. It can be very good like MRI. Unfortunately, it is very expensive. It's not covered by all insurances, and it involves a moderate amount of radiation dose, where MR, of course, is radiation free. So we think it's a supplemental or complementary tool, but at this point will not supplant MR as the main diagnostic pathway.
Does anybody else like to ask a question?
Yes, this is Larry. Can you hear me?
Loud and clear.
Okay. Thank you, Doctor, for your presentation. You remarked about the indexed area as being a, and correct me if I'm wrong, okay, as being a area where the cancer emanates from and metastasizes to other areas of the body. Did I get it correct?
Correct.
Okay, so is that index area always in the prostate gland?
For men who have prostate cancer, as we've discussed, many times it's multifocal. If you look at, if you've seen a lot of 12-core biopsy path reports, it'll say right apex 2 millimeters Gleason 6, right mid 5 millimeters Gleason 3+4, left base Gleason 3+4. So if it's multifocal, the question then is, how do we perform focal therapy effectively? So the index lesion, by definition, is the lesion that we see that's the largest in volume and the highest tumor grade. So the goal is to catch that and kill the index lesion before it's had a chance to spread. And by killing the index lesion, we've reduced significantly the risk of metastatic extraprostatic disease. So we don't have to kill all these small volume Gleason 6. Most of the time that will not continue to grow or cause the patient harm. But we certainly want to be sure that we have effective heating and killing of the index lesion to prevent the risk of metastatic disease.
Does that, thank you, does that necessarily mean, okay, that that metastatic cancer would originate from the primary index area? In other words, could there be multiple index areas? Okay.
No, when they've sampled the genetics of the prostate cancer cells, when they've done biopsies of bone or lymph node or other sites of metastatic disease, and they compared the cell lines of those metastatic foci to the cell line of the index lesion, there was 100% concordance. In other words, the cell lines of the other areas within the gland were not found in the metastatic deposits. There was something unique in the biology and the genetics of the index lesion that caused it to be potentially causing metastatic disease. And when metastatic disease occurred, it could always be traced back to that index lesion.
That's a critical fact, okay, in treating, is to understand where the index is.
Correct.
You know, that's really you're one of the first persons that have explained it in that kind of way. Okay, thank you.
I have a question here from Bob. What's the issue with a pacemaker?
Unfortunately, a pacemaker is not considered safe at high field MRI. It can induce arrhythmias, and the battery and the electrodes can have heating. Some pacemakers are now considered MR safe, but it needs to be done with a cardiologist to turn off the pacemaker and then to turn it on. So at this point, we're not performing TULSA on patients with pacemakers because the men are in the magnet for over 2 hours. And that may change in the future, but right now it's a relative contraindication.
Okay. Ira has a question. How effective is MRI in determining, I guess, the correct use of HIFU or TULSA-PRO, one versus the other? What are the reoccurrences with, I guess, with HIFU and TULSA-PRO? And then he's got a second question, but I'll let you answer the first one.
Well, the big difference between TULSA form of HIFU and the sonoblade or ablatherm transrectal approach is that with TULSA, we can treat the whole gland. And they can't do that effectively with the transrectal form of treatment. So when you looked at the data that I showed, the recurrence rate was higher with both cryotherapy and with sonoblade HIFU than it was with TULSA. By being able to monitor with real-time heat mapping with the precision and control that we have with the transurethral administration of focal therapy, the recurrence rates are the lowest of any of the forms of focal therapy.
And it's a two-part question. When will clinical trials be completed for TULSA-PRO? How many have been done?
So the clinical trial was completed in 2019. So now it's received commercial certificate of use. We're a clinical site and not a research site. I think there are 6 sites now in the United States with more pending. We're the first clinical site in California. So it's no longer considered a research tool, but it does not have a CPT code associated. So there's a difference between being allowed for use clinically and being covered by insurance.
Okay. Anybody else like to ask a question? You can open up the microphone, unmute yourself if you'd like to ask a question.
Yeah, this is Larry again. Okay, let me ask the doctor a follow-up question. Suppose the cancer has escaped the gland, some of the cancer. You would not only have to treat the cancer that has escaped a gland, but you still might want to treat the cancer in the gland, the index portion of the cancer, because if I'm interpreting what you're saying, okay, that the index, okay, unless it's treated, it's going to continue to metastasize to other parts of the body.
Correct. So you're asking a very challenging question in that we don't want to provide TULSA for men that we know have extraprostatic disease. The heat source doesn't do well in the fat surrounding the prostate gland. And the heat is propagated in the seminal vesicles because there's more fluid, so it's a little harder to control. So we could do a little bit of seminal vesicle disease, but the other question I think you're asking is many times a urologist, if he knows a man has extraprostatic or metastatic disease, will suggest a prostatectomy to help with disease control and reduce the likelihood of bleeding or other problems of having a large bulky tumor in the gland. TULSA-PRO can do that treatment in a safer and faster way with lower risk of harm. But that's not what we've been doing. I think that needs to be considered on a case-by-case basis.
Let me refine my question a little, doctor. Thank you. You know, if an oncologist comes up with the diagnosis that a man's has prostate cancer in other parts of the body, he may treat it differently. Okay, he will treat it differently probably than if it's local, if it's in the gland. Okay, but he would treat it maybe with hormone therapy, okay, which is, you know, helpful, but many times it's not a cure. But without treating the index area by the way you've defined it, that cancer will keep keep metastasizing from that particular area. Okay.
Well, many times these men are treated with a combination of ADT and radiation,
Yes.
or ADT, and now we could consider TULSA, but the ADT alone is going to really knock out the tumor in the gland. It may not be curative, so the question becomes, I've not seen any evidence or a trial that has been designed to answer the specific question I think you're asking.
Yes.
In other words, how does performing TULSA and perhaps ADT help a man with extraprostatic
Correct.
disease?
Correct.
So that's a good question, but I don't have the data to provide an accurate answer regarding outcome.
Is somebody working on that kind of study? Okay, because that would seem to be that landmark study if that was.
Well, I think that the whole focus of focal therapy is to
Yeah.
provide men with intermediate risk cancer an option of either active surveillance or
yeah.
surgery. So that's the main purpose of this. I think
Yeah.
as an adjunct for men with advanced disease, Gleason score 8, Gleason score
Sure.
9, close to the capsule, we need to do more trials and we need to get more outcomes.
Yeah.
So that'll be ongoing on a case-by-case basis, but I don't have any studies to quote you to demonstrate efficacy at this time.
That kind of study, I think, for men with advanced cancer would be very compelling, because
agree.
not only do they want to treat it in other parts of the body, but they'd want to get rid of the source of the cancer in the index area.
Especially with the low risk procedure
Yes,
of TULSA
yes.
compared to surgery. I mean,
Yes.
you don't want to have all those harms of ADT and other things and have the side effects of surgery at the same time.
Thank you, doctor.
Our next question is from 427126. And this person asks, let me get back to their question because this just jumped. Let's get back. What is that? Now we get down to dollars and cents here. What is the cost of the TULSA procedure?
The cost of TULSA is between $25,000 and $30,000. It's a little bit more than the sonoblade or transrectal form of HIFU because we're doing this in a controlled operative setting under MR guidance under general anesthesia. So there's more costs involved to the patient, but we think the benefit is that we have more control and we have better outcomes. There are some types of billing codes that we might try which have not been validated yet. And there are strategies to help men who need help financially to allow them to proceed with this treatment.
So Neil, let me ask another follow-up question if I
Sure.
could. So in regards to what Neil just asked about insurance, when do you think more insurance companies, I know this is just a guess, when do you think more insurance companies will provide coverage for this kind of technology?
We're hoping in the next 2 years. I mean, I think the managed care plans would be all over this because we can provide total gland control with better long-term outcomes and some alternative treatments at a much lower overall cost than surgery or radiation. Radiation, I think, costs over $50,000. And surgery, if you include the hospital stay and all the supplies you need post-op, including continence supplies and medication, that TULSA, I think, compares quite favorably regarding overall cost. So we're hoping that with increased utilization, we'll get approval with CMS to get codes and coverage for this.
Thank you, doctor.
Ira wants to know, do you recommend TULSA-PRO or HIFU for men on active surveillance?
I think that if a man is being maintained on active surveillance, he should stay on active surveillance until we can determine that he's progressing. As we pointed out in the talk, by 10 years, 50% of men fail active surveillance and need to have definitive treatment. So the question is, how do we monitor those men to select the ideal time to offer them treatment before the horse has left the barn, so to speak, and they may have extra prostatic extension. So by monitoring them with PSA, MR, and biopsy, we can identify when a man might be a candidate for definitive treatment. And then, of course, it's the discussion between the man and his doctor, which form of treatment would have the best outcomes and the lowest harms. So I think for men who progress on active surveillance, who have grade group 2 or grade group 3 disease that's gland contained, focal therapy should be considered a viable option.
Larry Weaver would like to know, my prostate had 10 of 12 cores positive, 10%, and 85% cancer based on the prostatectomy pathology. What would you do about finding the index lesion?
Well, again, I'd have to see what his MR looked like, but MR is very good at finding the index lesion. We can find it in over 90% of men. And if we can see the index lesion, and if we can prove it with a targeted biopsy, and if it falls within 3 centimeters from the urethra, we can treat it with focal therapy.
Ravender says, I think there is a C code available for TULSA, which reimburses around $12,500 for the treatment. The reimbursement could vary across different sites.
Yeah, this is all evolving very quickly, and I don't profess to be an expert in insurance coding and reimbursement. We have other people to assist on that, but that's really not my area of expertise.
Okay. Ira has said, as I understand, Dr. Colts from Canada did the initial work to develop TULSA-PRO. Are these results part of the clinical trial? How many TULSA-PROs have been done in the USA, and how many have you done?
Good question. Dr. Klotz is a great guy, and he's in Toronto, which is where Profound Medical is based. So he was clearly involved with the clinical trial and provided data for that. I think there have been, I don't know for a fact how many TULSA-PRO treatments have been done. I think it's over 200 at this point. There are 6 active sites in the country. We just started doing our treatments in November, and we've done 5 or 6 patients, and we have a bunch of patients being scheduled for May. COVID has clearly put a crimp into our ramping up our treatments, but now that everybody's getting vaccinated, our volume of treating men is clearly rising significantly.
All right, let's see if anyone else has any questions. Stephen asks, what resistance are you hearing from the insurance industry that is causing them not to approve this treatment?
Well, it's very similar to them not wanting to pay for prostate MR. I mean, remember, it wasn't too long ago that when a urologist would order a multiparametric prostate MR, a lot of times the insurance would only cover it if the man had a negative biopsy. And based on all the data we now have with the PROMISE and Precision trial, we know that's just a silly argument. But unfortunately, the insurance companies are always about 2 years behind where we are with clinical evidence. So again, they move very slowly to embrace change and to provide coverage for techniques that we now know to be more efficacious and more cost effective. So again, there's just a hesitancy and a lag that I think frustrates all of us in this space. But again, I have no influence over them.
Would anybody else? We have about 10 more minutes if somebody else would like to ask a question. Either unmute your mic and ask the question directly or post it here on.
Can I ask a question?
Please do.
Am I unmuted? I can't tell.
Yes, Dr. Metzger, you are unmuted.
I'd like to thank you very much for a very good presentation. I think the biggest part that I see in the practice of urology is the addition of the MRI, a parametric MRI to the whole equation. We fought that battle for a long time to try and get that. When you fuse that to the ultrasound, then at least you've got a chance to find, as you have indicated, the place that you need to be. I just worry a little bit about calling half a prostate ablation focal therapy. Focal therapy to me means, you know, going after a small area that's significant and leaving the rest alone. But a lot of your slides showed full gland treatment or half gland treatment. I'm sure that's stretching the focal definition a little bit, but I certainly applaud your efforts, and this is where it's headed. And you're right about the outcomes after prostate surgery. We treated people that didn't need it, and they did the best. And then the people that needed it didn't do so well. And now we're, you know, it's kind of coming out that we didn't know it at the time because we just did what we thought was appropriate. But it's interesting how all this comes and these new things come along to take their place that are improvements. The other comment is when the 30 megahertz ultrasound comes out next year, what are you going to do with all these MRI requests?
Well, you know, I really like the micro ultrasound. I've seen it in action and it's very accurate, but it's very user dependent, and it's going to take the urologist a lot of time to learn how to do that. And so the question is the reimbursement going to worth their time, and how is it going to compare to the accuracy, because it's going to be very user dependent. I think in certain hands, it's very good. But I think with the volume of men that you're seeing in your office, to spend a half an hour or so to do a quality prostate ultrasound and then to review the images accurately it's going to be cumbersome. If you send the man for an MRI, you can get accurate results, and you can be doing it more efficiently. But getting back to the insurance issue, my understanding is we're still struggling to get reimbursement for a uronav fusion technique. So we know it's a more accurate form of biopsy, but if the urologist wants to use the best fusion software out there, many times there's no extra reimbursement rendered for providing a higher level of care. So there are a lot of insurance issues that we have to work on to allow us to provide cutting edge treatment options.
Yes.
I have one question here from Ira. How does doing the procedure in bore improve results versus MRI guided three-dimensional machine?
Well, is the patient talking about focal therapy in bore or in bore MR targeted biopsy?
I think I'm going to let you ask that, Ira. You want to unmute yourself and
maybe could you talk to both of them?
Sure. With MR targeted biopsy, we can be very accurate in hitting an index lesion, but we don't have the ability of mapping out the gland and doing a 12-core biopsy. We don't have the time or the ability to sample the rest of the gland. So we put 3 or 4 needles into the index lesion that we can see under MR, and we don't sample the rest of the gland. When we do that, I've done studies with Steve Raymond at UCLA, and we pulled our in-bore MR targeted biopsy data, and our outcome data is outstanding. For a Pi-rads 4 or 5 lesion under MR guidance, we find clinically significant cancer over 88% of the time. When you have a standard ultrasound fusion biopsy, the urologist is requested to do 2 or 3 needles into the index lesion, plus do their standard 12-core biopsy. So by doing it that way, it's a little faster, and we get to map out and see what we may have missed under MR. We may be surprised, and there could be another high-grade lesion that was hiding or lurking that was missed. Regarding focal therapy under MR guidance, we have a feedback control so that the ultrasound is directed to shut off when the temperature gets to 55 degrees at the contour of the gland that we draw, so that we can get 2 millimeter precision to be ensure that we can completely treat the affective tissue and spare damage to the neurovascular bundle or the urethra or the rectum. So by doing it under real-time heat mapping with that degree of precision, it is what allows the TULSA outcomes to be so much better than other forms of focal therapy.
Are you using TULSA-PRO versus HIFU now? Or are you still using HIFU?
Well, I'm a radiologist, so Dr. Fugach, the urologist, spoke to your group about HIFU that he can do transrectally. He's welcome to work with us with our transurethral HIFU at our site at West Hills, but there are two different things. And again, the challenge with transrectal ultrasound is that many times if the gland is too big, they have to have a simple prostatectomy first. They can't treat the whole gland effectively, and there are risks of damage to the rectum, the urethra, and the neurovascular bundle. So it's very good for a peripheral zone lesion. It's not so good if the index lesion is in the transition zone or further away from the rectum. So, there are different tools and different aspects. So I think it's not one size fits all. It's nice to have a lot of different options so that we can bring to bear the best for the specific indication.
Thank you.
If there's no other questions, is there anyone else who'd like to ask a question? We have 4 more minutes. With that, I think I'd like to say that join us next month on the 4th Thursday at 7 p.m. Pacific Daylight Time, when we will look at Medicare Essentials with HICAP here in Orange County. And if you would like, email us at prostateforumoc@gmail.com and get on our constant contact email list if you're not already on it, and get our weekly newsletter from Dr. Metzger of the latest developments in prostate detection, cancer detection and treatment, and also our meeting announcements, as well as other significant community events. If there's no other questions, I'll thank you very much, Dr. Princenthal, for your help. Outstanding presentation, and we look forward to meeting with you again in the future.
Thank you very much.
Have a good night, everybody.
All right, we're signing out. Thank you, Doctor.
Pleasure. Thank you.